Welcome to the University of Michigan Dentistry Podcast Series, promoting oral health care worldwide.
Well, do you think AC will sign with the new football league?
I don't know. I don't know if he's going to give him enough notification anyway before the league starts. They start in a couple of weeks.
He might if they'll guarantee him a salary, whether the league folds up or not.
Yeah. I think he'd probably hook on with a NFL team anyway if as it gets going.
I think he probably should.
Yeah. But I don't know. How about Riggins, though? Yeah.
He can demand whatever he wants after that Super Bowl.
Yeah. Just a minute, Bill, here.
You know, Craig, I've been waiting for this checkpoint for about 15 minutes now.
Is that right?
And Dr. Metzger, he seems to spend most of his time with all the people that are always ahead.
I know what you mean. I know exactly what you're talking about.
Excuse me, would you take a look at this?
It's okay.
Thank you.
Hi, Dr.
How you doing?
Miller.
Okay.
I'd really appreciate if you can take a look at this and tell me what I'm doing wrong.
Okay.
I've been playing with it for a little while, and I'm just hoping it can come out all right.
Well, I don't know. It looks really, really good. You have a little rough spot right here, and I think if you smooth that down just a little bit, it looks excellent. You've done a real good job.
Do you have
Okay.
any other suggestions for me, or just
I don't
keep
think so.
doing
Let
what
me see
I'm
his
doing?
arms. No, I think you're being too hard on yourself. I think you're doing a good job. Okay.
Thank you.
All right. Tom, is there something I can help you with?
Do you think you could help me with this thing here? I just have a little problem with the smoothing out. I'm not sure if, how I should work that out.
I think it's fine.
I need a rubber base check. I'm a little bit worried about one of my margins.
You know, your occlusal floor isn't flat.
Oh, well, I'm aware of that, but I'm concerned about one of the margins.
You know, you're behind just about everyone else in this project. You better hurry up.
Yeah, I know I'm behind, but I've been working nights in the lab to try and catch up. Well, I guess you don't remember that I told you I sprained my wrist and I couldn't use my hand for a week.
Oh.
So you came all the way in from Jackson today, huh?
Yes, I did.
Were the roads pretty bad today, or?
They were terrible. It was like a sheet of ice. It took me 2.5 hours to get here.
Wow.
I'm lucky I left earlier. I wouldn't have been on time.
Okay, well, we'll have an instructor come take a look here.
You haven't had a periophase completion yet.
Oh, that's been completed. Dr. Peterson okayed it last time.
Oh, I don't see the card in here anywhere. Another student trying to get away without instructor approval. Ma'am, he's not going to be able to see you today. He'll appoint you at another date. Ross, I'd like you to get things squared away for next time and maybe review your procedures.
Okay.
Okay. You ready for a check?
Yes, sir.
Okay. How are you? You can go ahead with that.
You know, this Ted Miller has improved tremendously just in recent weeks. I think he's going to be a great dentist.
Hi, Dr. Youngblood. I'd like you to look at my maxillary posterior teeth, if you could. Worked pretty hard on it.
Well, the inclination looks real good. They seem to be in line with each other. I think it'll be okay.
Great, thanks.
So I think it would be a little nicer to get
After all that work. Okay.
If you're worried about how far away I am.
Just okay.
You know, this is really a very easy procedure to do. I don't know why you're having so much trouble with it. Did you ever work with your hands before you came to dental school?
Well, yeah, sure.
I think it still needs a lot of work. Try again, okay?
That bridge seated nicely. The draw is very good, thanks to the taper you put in those abutments.
Oh, thanks. I was pretty pleased with that myself there. I was wondering, Dr. Mevis, if I was going to do this other bridge here, how would I handle the taper on that molar that's tipped forward there?
That bridge is assigned to graduate clinic. You don't have to worry about it.
I've asked my instructor to check my work. He should be here any second. He's with another student.
I've been wanting to talk to you about my teeth. I've really been negligent about them in the past, and I want to start seeing my dentist regularly and taking care of them. Is there anything you could suggest so that I don't lose any more teeth?
Sure. Here, let me adjust your chair so we can talk about this.
Okay. I've been trying to stay away from sugary foods for a number of reasons. I know sugar causes cavities. Does sugar cause the periodontal disease too?
Oh, I thought you were ready for a check. I'll come back later.
Well, plaque is the culprit that causes both dental diseases. Now, plaque needs sugar to cause cavities, but plaque alone can cause periodontal disease.
You know, I know it's important to brush and floss the plaque off. Will that be a problem with my bridge?
Well, next week when I put in your permanent bridge, we're going to show you how to do this. That shouldn't be any problem. But you are right, it is very important to keep your teeth very clean. I wonder what happened to Dr. Mevis. Let me see. I'll go see if I can find him.
Okay.
Well, Dr. Mevis is in the other clinic. It'll probably be 10 or 15 minutes before we can see him.
If I had only been quiet, we would probably finish a lot sooner, wouldn't we?
Dr. Ray, would you look at this, please?
I can't understand it. You're the 5th student to do this. Apparently you focused the reducing flame on the bridge and the investment, and now you've perforated the crown.
When I called an instructor over to come and take a look, you're still not feeling any numbness at all?
No. Okay.
Doctor, I've given 2 mandibular blocks and I can't seem to get anesthesia. I've given the injections the same way that I have with other patients, and I've never had this problem before. What should I do?
Don't worry about it. Some patients are just resistant to anesthesia. You think you'll be okay without it?
I guess so.
Oh, it looks like we did a pretty good job here. Did you ask for a polishing check, Miss Judge?
Yes, I did, Mrs. Peterson.
Okay. Did you use disclosing solution to check your work?
Yes, I did.
Good. Let's see. You checked now with disclosing solution myself. This really doesn't look very good. I'll rinse it just to be sure that we don't have a lot of excess disclosing solution. There are a lot of areas that have been missed here, Mrs. Judge. Can you see these areas I'm talking about?
Yes.
Interproximally along the buccal surfaces, there are a great many areas. Lingually, we have a lot of disclosing solution left, and also interproximally on this left side. This really is not good, as you well know, to have so much disclosing solution still clinging to the teeth in these areas. Would you like to make some notations about this?
Yeah, I thought I'd done a pretty good job.
Well, there certainly is something wrong. I think you should make notes that there is repolishing that needs to be done in both the upper and lower arch on the right side, interproximally and along the gingival third. And on the left side, the same situation, interproximally and buccal surfaces, and a bit on the lingual at the gingival third. This is a great many areas. Obviously, you will have to repolish. I don't know what caused this, but if it's because you're in too much of a hurry, then you better slow down. Go back over those areas I pointed out to you and let me know when you're ready for a check again.
Yes, ma'am. Gee, things look pretty good. I think we're all set for a polishing check.
Did you want a polishing check, Sue?
Yes, I did, Mrs. Peterson.
Okay. Let me check it for you. You'll notice I'm drying these areas very carefully. Sue, this is so important when checking your polishing, because if you don't have the teeth completely free of saliva, the disclosing solution sometimes will not stain the plaque. It will stain the saliva instead, and you will have an inaccurate estimate of what plaque might be remaining. So I thought I would mention that.
I don't think I dried quite that thoroughly.
Well, we'll see how it looks. Okay. Okay, Sue, would you like to look over here at tooth number 3? You may notice there's some disclosing solution clinging to the mesial of that tooth.
Mm-hmm.
And the rest of the tooth is polished quite well, so just looking at it, I would guess that perhaps you were not adapting the polishing cup as well as you might in that area. This is a common mistake, and it could be that you just were not using enough pressure and using the edge of the cup to go into that interproximal area. The same problem exists on the bicuspids and the distal surface next to that tooth. And looking down in the lower arch just quickly, I notice a few other areas in that same situation. So let me take a look at what you've been doing. Would you like to sit down and show me how you've been polishing? Perhaps I can better diagnose the problem when I can see what you've been doing.
Okay.
So just polish as you have been doing. Okay, try using just a bit more pressure so that the edge of the cup does go into the interproximal surface.
Oh, I can see that does go in a little bit further than what I was doing.
Much better on those areas that you had missed. That's good. I think you have it now. Okay. I'll give you the opportunity then to go back over those areas that we talked about. And then when I come back, I can check it again for you.
Okay, thanks, Mrs. Peterson.
64.
Apparently had an occlusal adjustment, but I don't think that would explain the whole ball of wax. I'm really reaching. What I'm trying to do is see if there might be some sort of a dietary or environmental factor why he's wearing them down that much.
Yeah, I was almost thinking of like chewing tobacco or something.
Tobacco chewers are classic for that, and when I was out on the reservation with the Navajos, same kind of thing. By the time most of them were 30 or at least 35, they'd grind off all the cusps on the posterior teeth. There it was dietary because the sand in the diet and that sort of thing. They were cooking outside a lot.
What I was thinking in there, if you feel firmness in his teeth and just bites down, you feel some firmness in the anterior. So my thought was that maybe when they did his posterior vision, they just did it out of occlusion. And forced him to have an anterior bite. So, I mean, those would eventually wear down.
Oh, you mean when they put the bridges in, they put him in shy of occlusion, and the anteriors wore down to that level?
Self-adjusting dentition.
When they put the bridges in at first, were you biting on them?
I don't know. When put my bridges, what?
Okay. When you had the bridges put in, when they first made them for you, were they touching upper teeth against bottom teeth?
Somewhat. But I don't know. No.
Okay. Where were you doing most of your chewing, in the back or in the front?
I would say the most I chewed in my front.
You might have something there. You might have something there.
Bicuspid. Okay.
One problem I thought was on the lingual wall. I don't know if I saw too much tape.
Yeah, you sure did.
That was the one problem that I saw.
Also on the distal, okay, if we look at the tooth as it was originally, okay, if this is buccal, we've got our 1.5 shoulder and our reduction. And I made the point that all too often we don't reduce the buccal cusp enough. Now you've done that quite nicely, okay? And I think in keeping that in mind, you may have gotten into the problem of then over-reducing the lingual cusp, and then, I don't know if it was an indirect mirror problem or what, but we do have super taper on the distal.
I saw that.
And the lingual.
That was the one problem that I saw.
Especially right here in the distal lingual line angle of the tooth. Okay. In a clinical situation, you've done what our models ask. I suggest to you that you probably want to keep a little bit more width of shoulder here in the interproximal. Okay. Just give your lab man room to get the metal, the opaque, and the porcelain there for color stability. Okay? The smoothness of the prep is very, very nice. Nice finish, good, very good, discreet, readily identifiable finish line. And let's see how our... We can't tell, but that's all right. Well, I mean, if you draw a line right straight across, obviously you've got enough room for 1.5 mm or so of porcelain. One other criticism that I might leave with you, okay? Never in a clinical situation would you want to leave anything like that tiny little bit, okay? It's right at that point where you have a deep fissure, probably from the central groove, maybe from the distal pit, that area where the enamel is really badly leaked. You'd want to just go in there and just lightly bring that up. I don't like to leave. You betcha. Okay, and that, you know, it's all right to leave stained dentin. Okay, that's got quite a little catch to it. So I'd probably take that out. Okay. Very well. Let's sign this off. Anything else, Craig?
No, that should be it.
Okay. So what are you going to go on to now?
I'm going to start the temporary on that. And then finish my posting for
Okay. You're in good shape. Okay, but it'd be good to have this well underway.
Okay.
Good enough.
And how many coats of dye spacer did you use?
2.
2. Do you know how much thickness that'll give you? Any idea?
Probably millimeter.
No.
Less.
Depending on how old the dye spacer is, if there's been a lot of evaporation of the solvent, you can get up to 10 or 15 to 20 microns per thickness, okay? Millimeter would be great. All you want to do with the dye spacer is what? What are we trying to compensate for?
The cement.
Okay, and what would be the minimum cement thickness for zinc phosphate cement? Recall what that might be?
No.
Okay. Be about 40 microns. That's why it's so critical when we mix it. You mix for like a minute and a half and equal amounts of the powder and liquid so we get a maximum amount of powder incorporated, but not increase the cement thickness too much that might raise the casting when it's cemented. And by using dye spacer, you then allow yourself a certain amount of space available to make up for that 40 microns, which will then allow you to have a tighter fitting casting. And research is also showing that will increase your retention about 25%.
So how many microns do you get per layer of dye spacer?
If it's a new bottle, probably about 12. Okay, and if it's an older one where the material's gotten thicker, you'll get 20 microns. So if you use 2 layers, you may get up to 40. So it depends. You've got to be critical on how old the dye spacer is.
I bought it during...
And how many times it's been open and how long it was left open. So that can be subjective, okay? But usually if you use 2 layers, that will give us a better fitting casting, and it'll be easier to seat, but it may feel a little bit loose in the mouth. That's why we like the rubber dam on there, okay, so it doesn't wiggle around. But after it's cemented, it'll have more retention than one that is real tight before you cement it, because it'll go into position further, and it'll be a closer apposition to the parallel walls. Okay, study's been done. If we don't use a dye spacer, when you put the casting in, it'll have a rebound effect, and it won't be seated all the way. So where you've got parallel walls available, you're going to be a little bit off the wall, and you won't be able to get as much retention. Okay, so you're getting the benefits of some good research. Okay. All right. Let me check your contacts. First thing you're going to do will be what? When you go to try to place this, what will be your first order of business?
Well, I'm just going to try to place it, and I'm assuming that my proximal contacts are going to be a little too much, and then take them down until that fits, and then check the occlusal contacts.
Okay, that's good. Check your proximal. If it's too tight, a way you can determine where to take it off is put floss on it. Have somebody come over and help hold the casting while you floss it. Find out if it's the mesial or the distal. Okay, so you don't blindly just take some off and say, oh, gee, it was the mesial. Okay, find out which one it is. Another thing you can do is take a regular carbon type pencil, alcohol it off, and then mark, like in this case, on the mesial of 26 and then on the distal of the other bi. And then it'll leave a marking of graphite, and then where the contact is a little bit too great at the interproximal, it'll leave a deposit of graphite. Then you can take it off, zzz, try it again. So you know exactly where to take it off, so you aren't blindly going in there saying, well, trial and error.
Okay, so...
Okay, I wanted you to just check this again.
Okay, did you just repack it?
Yeah, I just repacked it.
Okay. Did you self-evaluate it?
That's one. I just did. I'm just going to mark them down right now.
Okay.
Okay?
Mm-hmm. All right. Okay, this is much better. Don't you think so?
Yeah, I think so too.
Okay. All right. Okay, so tell me, what do you think?
Okay. I thought that my surface and color was fine. All right?
Okay.
I didn't think there was too much pitting at all.
No. Mm-hmm.
All right. And my margin integrity, I thought it was better than before. I gave myself an S, satisfactory.
Okay.
I still think that I can improve on it.
Okay. All right. What else?
My occlusal anatomy, I thought was okay.
Mm-hmm. Yeah, you follow what we had on the tooth, not that many grooves, so that's fine.
So I give myself an R.
Mm-hmm.
And my axial contour and proximal contact, I think I can improve it. I got a good proximal contact, but I think I can improve the box portion.
What do you mean with that?
Okay, I think I can make it smoother because I don't think it's as smooth.
Okay. There's something else about your axial contour, okay?
Okay.
And let's look at it. Okay. Look at the proximal contour, okay? You can even look at it in the mirror, if you can.
Okay.
All right? How is the amalgam in comparison with the axial contour of the tooth? Okay, let's follow the Explorer and see what happens.
It jumps.
Okay, so what you
I'm
think?
going to have to take down at the gingival.
Okay, yeah. So we are a little bit too bulky.
Too high, yeah.
Okay, because your margin is right at the cavus surface margin of your preparation.
Okay.
Okay, but you are bulky.
Okay.
Okay, so right now that the steel is fresh, you will be able to carve it down.
Okay.
Okay, what instrument would you like to use?
I'd like to use my Ward's carver.
Okay, so before it gets too hard, okay, try to carve it back
Okay.
with the Ward's carver.
You hear that little noise right in there?
Yeah, I can see it coming on.
Right in here. Okay, let's take a look at those. Let's take a look at that first. Let me have you just sit right here a moment, and I want you to see if you can. Let's look at that one on the mesial of 17. Mesial buckle 17. There you go. Okay, now what I want you to do is just very lightly, as if I can take this Explorer out of your hand. I want you to very lightly go down right there. Okay, there you go. There you go. Okay? Now, what I want you to do is take your 1112, use it like that Explorer. Okay? And I want you to feel it before you remove it, though. I want you to feel it first, so it should be real light right in here. And if you can't feel it, don't take it off.
Right here.
Right, yeah, there you go. Go a little further in. Right, it's right in there. Okay, and then once you feel it, push up with the curette. Take it down. There you go. Okay. Now go back and feel again. And then, so you're using your instrument not only for removing, but for detecting. So go back and feel again. If it's smooth, then you finish it. Okay, I got you one right here. ahead and close a little bit. Head and close. See, when it closes, it relaxes the muscles. Now bring your instrument right. Okay, still there. Okay, still there. So put that right where that. Here. Now you're getting the instrument into under the contact area. There. Did you hear that little snap?
Mm-hmm. That was it.
He probably felt that little snap. Yep. And if it's still just a little rough, then do a little root planing action, which is 3 or 4 little light strokes, and that will take care of it. Now what I'd like you to do is look at a couple of areas here and use that same Explorer technique on the lingual in here, and then we'll check everything off.
Okay.
Okay?
Thank you. Sorry.
Sure. You were right about here. I'm going completely almost past the contact area, because unfortunately that's where calculus is. Unfortunately. Now let me show you the difference of what I'm doing and what you were doing. Okay, let me get the right curette first. Okay. I'll have you turn your head that way for me. See how far my curette is in? Mm-hmm. And that is generally a stark realization when you start debriding that you can't imagine that curette can go in there far. But if you look at the width, though, I'm only that far. Mm-hmm. Okay, so let's do that. Watch this.
Okay.
Hear that?
Okay, I was having some trouble ascertaining.
Look how far I'm in there.
Mm-hmm.
Hear all those noises? That's subgingival calculus. Now what I'll do, open just a little wider for me. What I'm going to do is I'm going to do the same thing from the palate and go just as far in. Okay?
Sure to reach.
Okay, and then I'll stop when I don't feel anything or don't hear anything. See, there's nothing there. Now, if you look at that, tooth, and if that's the contact area, our research shows that most calculus is right there. Now here's what your curette's doing. From the buccal, your curette comes completely over here. From the palatal, your curette comes completely over here. So what do you see is going on? It's overlapping.
Sure.
So you're giving it your best shot.
What is your main problem? Find out which tooth it is?
Find out which tooth it is. Symptoms, sometimes pain to cold, sometimes not. This is one I got from ODC. I didn't like it, so I took it so I could see the distal of this.
Okay.
Because when I first touched 17 there was a tremendous response to the cold.
Okay.
But now I go back in there to, confirm it, and it's just normal like every other tooth.
Okay.
And no electric pulse response on any of those 5 teeth.
Okay.
Nothing.
Have you done cold testing?
Mm-hmm.
Okay.
Twice.
What did you get on that?
Well, like I said, I got at first time I did, I got quite a good response on 17. I thought, great, I'll get an x-ray of 17 and really see it. Then I get nothing on the electric pulp test on any of those teeth until I get to 22.
What do you see looking at all those root canals?
Pretty much obliterated.
That's right, so they're very small, so this would be expected. Okay?
Okay.
In addition to, if you had somebody who had electric shock one time out of the wall outlet, they're not going to respond to the little charge that you're getting out of that. Okay, so you have to ask them these questions when they don't respond and rule that kind of thing out. What do you think about the size of those fillings in there?
Pretty large, very large.
Real large, okay.
Yes.
So you can also look at and surmise that that has had a lot of damage on it. Okay, that one has less damage, and that one you really don't know because there's a full crown over it.
Right.
Is any one of them look periapically like there's something going on? Yeah, both the back ones do. Okay, the distal root there and the whole root back in there. So that really you can't tell, but there's no percussion sensitivity yet, right?
No.
All right, so we wouldn't expect that the tooth has died and started the inflammatory process at the end, so that you would not see that. So what we're relying on is the pain that she's having. It's diffuse in nature. Okay, you've got a huge filling back there, and that reacted hypersensitive to cold. Did you test the other side? Same tooth on the other side?
No, I didn't.
Okay, with the cold you'd want to do that because you want to see maybe both teeth are hyper-responsive like that. So you want to get an idea in that patient what each tooth looks like. So you can't go just adjacent to it, but you've got to go across the arch and find out what that's like.
Even when I did it the second time to confirm it, it wasn't as hypersensitive.
Right, and it will always be that way because you've got to let the tooth come back up to temperature before you retest it again.
It was about 15 minutes because I had done my...
That's right, it takes time.
Oh,
okay, in these cases. And I would say from looking at this, from my clinical experience, that it's the last one there. But what I want to do is be able to convey that to you as to how do you get to that same point, okay, because we don't want to be in the wrong tooth. So let's get some more ice, test the other side, and find out what's going on with that. And I'll watch you while you're doing that.
Okay.
And let's see if we can figure this out. There are cases that I don't do anything on at that point in time if I can't decide. I give the patient a percentage chance. I say 50% chance that we're in the right tooth, or 85% chance. And if they say, well, I'd like to wait, then we wait. If they say, well, hey, I've had this pain long enough, I want something done, then you go by your best educated guess as to which is the main offending tooth, and you do that one. Okay, so let's find out if we can get the percentage up from 50%. Actually, right now we don't even have a percentage because I'm just going on radiographic view there, and that's not enough to even get into the ballpark of guessing right now. If you've got two teeth, then you've got a 50-50 chance, okay? And I haven't even gotten the two teeth yet. So let's see if we can get there.
It'll be later than that, really. You're talking closer to 11, okay? So he's got a long time to keep that tooth. Okay. That's what you want to think about. These back molars, and if you detect early caries on these teeth, you want to do it. You're better to get in there and do it. And he likes to move around. He's antsy a little bit, but that shouldn't want to deter you from working on it. He's very manageable. He just needs to be, when you manage him, you're going to have to be, well, more firm and just lay down the ground rules and say, you have to sit still, you have to do this. And get in there and get the job done and get done. So he does have that then, yeah. I think we'll live with the x-rays, okay? I'm not happy with the overlap on that one, but I do think rather than take some more on him right now, and looking back at the last x-rays, I don't feel we have any caries there. Do you feel comfortable with that?
Yeah.
Yeah. A surface 6, yeah. So go ahead and draw. He can go. You can let him go, and then we'll sit down and discuss the treatment plan.
We had fluoride last March, so
we wouldn't want to do it, yeah. Okay? See ya. Good job, partner. Let's take a look there, Scott.
All right.
No, keep on working. I want to see how you're using that instrument right now, okay?
Yeah, I'm just cleaving off the incisor and the
without doing any changes, just hang on to it the way it is. Go back in there and try just a little more. Now, without changing, without moving, look at your fingers. See how white the end of your finger is? And now when you take it off, look at the impression in the end of your finger, okay? You're holding it much too hard, okay? And you're prying, okay? You're using your whole hand to literally pry. And it's not a prying action, all right? If you do this type of thing, you're going to either break instruments or you're going to break a tooth, one or the other. You've got a tremendous amount of muscle mass up here and a lot of leverage on that when you do that type of thing. You can use that in oral surgery when you extract teeth, but not down here. It's a sliding action, okay? You can look at the bevel, And it's merely a scraping action like this. You can use the side of the instrument, and it's a scrape. And if you look at my fingers, say I'm not white fingering it, okay? It's a more controlled thing. If you get it too tight, it's hard to get it without giving a shake to it too, okay? So let's see what you're trying to really shave.
Labial floor.
Okay. Now, what you want to do, most likely, that's a little difficult, so you can't even get up on the angle. So more than likely, either a hoe, which has a little more angle to it, okay, see how that reaches up there now? Or even a hatchet. You hear the difference in the sound versus what you had? It's more of a scraping now. And see, I can put it on the cervical floor. Can you see in there?
Yeah.
And then you just scrape up, and you scrape in like that. And if you go to the other end of the hole, then that's going to take your cervical down. See it? And then you can come up. Okay?
Okay.
So, now, let's go to a hatchet, too, because a hatchet would also let you do something here. See, a hatchet goes in like that and sweeps across. See that?
So you're using it sort of...
Now, in your case, you'd be on this side. You can use it from the back, just like that. See, it fits in there. Okay. Now, when you get to your marginal trimmer, the marginal trimmer is basically the same instrument. You've got the correct one out, and that's a sweeping action across that floor. See, but if you look at it, see how I'm rolling it in my fingers? I'm not doing any of this, okay? I've got my finger rest, my hand stays in position, and the work then comes part of my finger action, not of my whole wrist or arm, okay?
Okay.
I think that'll help you.
All right, thanks.
So,
Am I ready for retention just about?
Yeah, try your hoe in there for a minute. I just want to see how you do that. See if you lighten up your grasp on it a little bit.
Okay, I want to get way in here and...
That's it, and just finger action. Can you hear it? It's doing the job, okay? And then scrape it across the floor. See, back and forth with a sweeping action. There you go. Now, the axial wall, so you can use the side of the instrument against the axial wall even. So, okay, that's it. So you just scrape up and down. There's your action, okay?
Okay. This is Dr. Johnson, Eddie. Gonna be working with us today?
Oh yeah, Eddie knows me.
Yeah.
We tried some other stuff before, didn't we, Eddie? What did we try? A stick? And then you had that little lower thing, the plastic thing that you bit on. This is, I think, the second or third one. Okay, Eddie, you've been through this once before, so you know how it's going to go, all right? But he hasn't, so we're going to kind of rehearse it. What I'll do is I'll mix it for you, and you can put a slide ejector in over here, and we won't want to have the cotton roll till the last minute, I think, because it usually just makes him salivate and move his jaw around and everything. And then as I get to the end of the mix, all right, I'll say, okay, and you can have Eddie open real wide, put the slide ejector in, and Eddie, you got to stay open. Remember how you did before, and keep your tongue down. I'll probably do it for this one. You know, I'll show you how it goes, but you kind of, when you get, it's different to cement a band than it is to fit it, because when you get the cement in there, you got cement all over your fingers, first of all, plus there's cement all over the occlusal, and you can't find the edge of the band. So you have to search for it by coming down with the band biter and find the cuss tip, and then slide along until you feel the edge of the band. And you can use like your fingernail as a demonstration. For instance, Eddie, I'm going to put the band on, and then I'm going to come down over here, and I'm going to push just on the band, and if you bite your top teeth on the thing, you'll push it down where we want it, okay? And when I say open, you open, and I'll move this thing to another spot on the band, and then you bite again, okay? So I'll say bite, open, bite, open. Okay. Okay, Eddie, open real wide. Okay, watch how this goes. You can get that slide ejector record ready, too. Oh, you got a loose tooth up there. Sorry, Eddie. See, now when I push up like that, see how the cement comes all over the place? And you try to wrestle it down with your fingers as much as you can. Okay, Eddie, stay open. Man. And then watch how this goes over the tooth.
So you can't see it. So you come over, now you find it. But if you have it at that angle, he'll bite right on his retromolar pad in the lower. Okay, bite, Eddie. Okay, open. And these anterior ones are easier. Bite. Okay, open, and you come on this side. Bite, Eddie. Okay, open. This is always a hard one back here. Okay, bite, Eddie. Okay, open. Now bite. Okay. Then, if you're not sure, you can wipe off the occlusal of the band. And you stay right open there, Eddie. And look at it and see if you got it down. That looks like it was before, doesn't it? Okay, then you cotton roll in like this across the occlusal. That blocks his tongue. Okay, bite together, Eddie. Okay, let's get this stretched out a little bit. Okay, bite right together, Eddie. Okay, and just hold steady. You doing all right? Okay. Okay, then you want to let it set good and hard, maybe 7-8 minutes, so that it's rock hard, then it's a lot easier to scale off. And then your B-scaler, you just pick around the edges and clean it up. I gotta wash my hands here, so I'm gonna put this in the sink for you. And it's a good idea sometimes to stay with Eddie. Eddie's an old pro at this, but I would stay with a younger child particularly, or have an assistant, because what they might do sometimes is chew on that, and then they misplace the cotton roll, and then you're not dry at all, and then this may be what happened. The reason that came loose was the cement was contaminated with a lot of saliva. You're always going to get a little, but you try to keep it from being very much.
You've been listening to a presentation from the University of Michigan School of Dentistry, which is dedicated to supporting open learning and open educational resources. This recording is licensed under the Creative Commons. It may be reused and redistributed for nonprofit use. Please attribute materials to the University of Michigan School of Dentistry and redistribute under this same license. For more information on how this and other University of Michigan School of Dentistry recordings may be used, visit www.dent.umich.edu/license.